So hello, today we will deal with schizophrenia and psychosis treatment. This means that many patients have positive symptoms in schizophrenia. This means delusions, hallucinations, thought disorganization, speech disorganization, and so on, behavior disorganization. These are all part of positive symptoms. We have dealt with that in another video called symptoms. And we know that we can say that positive symptoms are, we can say, psychosis, if we add something called agitation and aggressiveness. It doesn't have to be aggressiveness, but usually it's agitation, meaning acute agitation. So if you have positive symptoms, delusions, hallucinations with an agitation or with aggression, then we call it usually psychosis. We call it an acutely agitated patient that we need to treat. So it's a schizophrenia disease that on top of this schizophrenia disease, we have an acute agitation that we call psychosis because there are positive symptoms and agitation together. And now, what do we do? We have benzodiazepines and antipsychotics. These two groups of medication have to be given in patients with psychosis, schizophrenic patient with psychosis. As you hear in the name, antipsychotics, it's against psychosis. And benzodiazepines are those that calm the patient down. So we need to calm the patient down, and also the antipsychotics are also calming the patient down. It takes around a couple of minutes to calm the patient down, and then for the full effect of this antipsychotic to make its effect against schizophrenia, it can take 4 to 6 weeks. So antipsychotics are good when we are dealing with agitated patients because it quickly calms the patient down, but for full effect, for the main disease, schizophrenia, we have 4 to 6 weeks. So it can take, for many patients, it can take around 2 weeks. This is what we call when we deal with responders or non-responders. Responders just means that the patient is responding very good when we give antipsychotics. This means that usually these responders are responding to antipsychotics within 2 weeks. Those who are non-responders usually take much more, so 4 to 6 weeks. But please don't judge antipsychotics based on 4 weeks. So please give the patient 4 to 6 weeks at least. And then if you see that the medication does not help, then of course you need to reevaluate which medication you give, meaning we switch it. Don't use an adding therapy. Many doctors prefer to use an adding treatment method. That means that we have a medication that is not working so good, and then on top of that we add another one, and we hope that this combination will now work. But instead, I would suggest you to switch it. That we call switching therapy. That means that in a time frame of around 2 weeks, we start to reduce the dose of the first medication, and at the same time we increase the dose of the second medication. And usually this switch will take around 2 weeks. So never abruptly stop the first medication and then start the new one with full dose. No. You taper it down and you taper it up. Meaning you start with the lowest dose of the second medication and you reduce this first medication. Okay? So let's look at what do we mean when we say agitated patient? What does agitation mean? It's a tension. It's a mental tension. Restlessness. So it's a tension and restlessness, and it can be aggression also. Which are the causes of it? Usually it's psychosis. Then we call it's a schizophrenic patient with a psychosis that causes this acute agitation. You see, there are 3 things here we're dealing with. But it's in a schizophrenic patient who has agitation, it can also be caused by substance abuse. Cocaine, methamphetamine, and so on. Or withdrawal of alcohol, or withdrawal of benzodiazepines. It can cause an agitation in patients. So substance abuse needs to be ruled out. Please do a urine test and check if there's any substance abuse in the history, because the patient will tell you maybe, no, I didn't take anything. You take the urine sample, then you find out. The next thing, of course, we have also extrapyramidal symptoms if the patient took another antipsychotic already. That meaning you have a patient who has schizophrenia, this patient is taking antipsychotics, and now you see some extrapyramidal symptoms. Which are extrapyramidal symptoms? Extrapyramidal symptoms are those that are, for example, so Parkinsonism, meaning bradykinesia or tremor or rigidity. These are Parkinsonism symptoms. When we say Parkinsonism, we mean that the symptoms are very similar to those patients that have Parkinson's disease. But in this patient, he got these symptoms not due to the Parkinson's disease, but he got it due to the medication itself, the side effect of the antipsychotics. Then we call it Parkinsonism. So these are grouped in extrapyramidal symptoms. These are extrapyramidal symptoms. There exists also, except for this, akathisia and dystonias. Akathisia is something, for example, the patient complains that when he is trying to sleep, he's lying in his bed, then he has restless legs, and due to these medications, he's feeling restless due to his medication, akathisia. Or that we have dystonias, which is a repetitive muscle movement, twitching, So you see, it's a very confused postures, a very strange postures. This is dystonias. So we have three things to remember when we deal with extrapyramidal symptoms: akathisia, dystonias, and Parkinsonism. And within Parkinsonism, we have three things also. We have many more, but I will focus on these three things: bradykinesia, tremor. You see, bradykinesia, tremor, and rigidity. Bradykinesia is brady means a slower, kinesia movement, slower movement, meaning the patient is very slow when he moves. Tremor means handshaking, for example. So, rigidity, as we know, the arm is so rigid. I'm trying to flex the arm and extend the arm, and it's really rigid. That's rigidity. So these are extrapyramidal symptoms, and these extrapyramidal symptoms can cause acute agitation. So these in itself can cause acute agitation. Therefore, the causes of acute agitation in a schizophrenic patient are substance abuse that we ruled out. We check if the patient is taking any medication, meaning antipsychotics, that can cause extrapyramidal symptoms, because extrapyramidal symptom is the second one that can cause acute agitation. And the third is psychosis, meaning positive symptoms plus agitation or aggression in schizophrenic patients. So positive symptoms, hallucinations, delusions, and so on. Good. And now, what is the treatment now? We are dealing with the treatment now. Now you understand what I'm talking about. We have a patient now that is aggressive. When we have a patient that is aggressive, we don't have time to give some slow medications orally. We can. If we succeed, that's the best way to do it. You give a tablet in his mouth. If he does not allow that, meaning he's aggressive or agitated, he don't want to swallow the tablet, he just throws it away, he's aggressive with you, then you have to use intramuscular injection. You don't have any other choice. Or the second best option is a tablet that is dissolving in the mouth. So there exist two types of tablets. We have one tablet that is rigid. He needs to swallow it, so intact. Or there's a tablet, if you put it in his mouth, it will dissolve quickly, and he will not even recognize it, so he don't need to swallow it with water and so on. It dissolves in his mouth, and then it's absorbed in that way. That is a very good. So first we try oral tablet, then we try a dissolving tablet if that does work. If that does not work, then of course we try intramuscular injection. Intramuscular injection usually in the buttock region, or in the shoulder region, or in the upper thigh region. These are the possibilities. And then if the patient is aggressive, you usually need a team of nurses and doctors, and you need to coordinate this lay down of the patient in the bed and fixate him, if he's so aggressive. But you need a lot of persons. You need one on each leg, one on each arm. You need one person at the top on the head. So you need at least 5 people only to fixate him with your own hands. Then you need a sixth one that will make the strangulation in his arms. And then you need a 7th person that will bring the medications and so on. So this is a very, very good cooperation. You need a team, and usually this is done in psychiatric units. So usually, first of all, the police is transferring these patients into the hospital. And at which department? Psychiatry. Because in psychiatry, we have this special type of bed, special type of strangulation things. And therefore, it's very important that you bring these agitated, these aggressive schizophrenic patients to the psychiatric ward. And there, the team knows how to do it. They are educated, well educated in this. And then a doctor will come, so this is the 8th person, and he will now give an intramuscular injection of what? Now the question comes, what? We have antipsychotics. We have first generation, second generation. What does this mean? First generation just means that we have antipsychotics that were produced, let's say, before 1989. So these were the first type of medications. Before that, after 1989, meaning the invention of Olanzapine, after that, we started to call these medications second generation. So this is the main difference here, the time. But we also have a difference between them. First generation antipsychotics have more extrapyramidal side effects. This is what we talked about. What was it? Akathisia, dystonia, and Parkinsonism. Parkinsonism was tremor, bradykinesia, and rigidity. So, first generation antipsychotics will cause more of these side effects, extrapyramidal side effects. The second generation antipsychotics have less of those. But all antipsychotics can cause extrapyramidal side effects, all of them. And especially at higher doses. So the more you increase the dose of the medication, the higher the side effects will be. So, to remember now, we have first generation, second generation. And in which receptors they work on, this is another lecture. D2 receptors, I can just say, is D2 receptor, dopamine receptors in the brain, both of these groups. But we have in the first generation being more of D2, and then in the second generation we have other receptors also. For example, serotonin receptors is more there. We have a little bit weaker D2 in some medications in the second generation, but we will deal with that in another video. The main part to understand is the difference between extrapyramidal side effects. First generation, higher extrapyramidal side effects, second generation, lower. And now, what do we have? A typical first generation antipsychotic is haloperidol. Then we have typical second generation antipsychotics being Olanzapine, Risperidone, Aripiprazole, Ziprasidone. Let's name 4. There are many more and many more first generation. I will just focus on these 5 because otherwise this presentation will be 1 hour long. We will deal with other medications separately. So let's look at first generation Haloperidol, for example. Haloperidol. We have an intramuscular injection, we said. We will give an intramuscular injection of 2 milligrams. We start with 2 milligrams intramuscular injection into the shoulder, into the thigh, or into the buttock. I prefer buttock or thigh, bigger muscle, bigger tissue, less complications, meaning you don't puncture an artery or a vein so easily if you're doing it in the buttock region, as you would in shoulder and so on. But you can do it in the shoulder also. Good. Now, we will give 2 milligrams of haloperidol in this muscle. We will use a Z-track technique. Z-track technique means that I'm first extending the skin, then I puncture it in with the medication, and when I remove my needle now, I release it. Okay? This means that the skin was a little bit moved 1-2 centimeters down, and then when I punctured it, the muscle under the skin is fixed. So if you just move the skin above the muscle, that means that when I puncture it in this way, and then when I remove the needle and the skin goes back into the location, it will be a Z-track where the fluid, the medication cannot go out. If I would not do it, it will be a complete straight line, and then when I remove the needle, the fluid can go out from the body, meaning the medication will not be absorbed. So if I want the medication really in the muscle, I have to use a Z-track technique. Please check that out. Now, 2 milligrams, we have injected it. How long does it take for this medication to take effect? Usually intramuscular. If you can remember it like this, you have intramuscular and oral medication, meaning tablets. Intramuscular injections will take around 10 minutes to take effect and until about 30 minutes. So 10 to 30 depending on the medication, usually. Orally, we have 30 to 60 minutes, usually. It can take 1.5 hours for some. It can take even 5 hours for some, for time. So the time to peak effect, what I'm talking about. The time to effect is usually 30 minutes to 60 minutes. So there's a difference in definitions here. We have something that is time to effect. As we said, intramuscular time to effect around 10 minutes. But time to peak can be more. Let's say 1 hour, 1.5 hours. That means that the concentration that is the highest in the body, it can be more than 10 minutes. So the patient will start to feel something already in 10 minutes, but the effect will be even greater with time. So let's say after an hour. And with oral tablets, it's 30 minutes to 60 minutes. That is time to effect, but time to peak, 1.5 hours, 2 hours, maybe 5 hours, depending on the medication. And this is when we are dealing with acute agitated patients. This means that we have an effect for the agitation, for the psychosis part. Because if we want to have an effect of the schizophrenia itself, so we are giving these antipsychotics for the schizophrenia disease, then it can take 4 to 6 weeks, as we said. And responders will take around 2 weeks. So this is a difference here. Now we have an agitated patient that we treat with antipsychotics, and we want to treat the agitation, and that takes not so long time. It takes a couple of hours and then you're done. And what do we give? Haloperidol. We said that haloperidol is a first generation antipsychotic. This means that we have a higher amount of extrapyramidal symptoms. In order to reduce these extrapyramidal symptoms, we can use something called benztropine 1 milligram. Benztropine. Or we can use diphenhydramine. Or we can use a benzodiazepine. For example, lorazepam is very commonly used in psychiatry. Lorazepam, 2 milligram, for example. Usually when we are only dealing with restlessness, akathisia and so on, we start with the lowest doses, 0.5 milligram lorazepam. But if we're dealing with a high agitated and aggressive patient, we will give 2 milligram. Start with 2 milligram. Then, so we give haloperidol together with benzo, or together with the benztropine, or together with the diphenhydramine. Why? We reduce the extrapyramidal side effects. If we want to choose instead a second generation antipsychotics, let's take Olanzapine. Olanzapine we will give a 5 milligram intramuscularly. Here also we first tried oral tablet. Do you want to take the tablet? No. He will hit you if you do. Do you want to take a dissolved? That means you put it in his mouth and then close his mouth and then it dissolves in his mouth. If you can do it, try that. If not, then intramuscular injection. Same technique, Z-track technique, and we will use a 5 milligram Olanzapine in the beginning. And the maximum dose here around 20-30 milligram. The same with haloperidol, 2 milligram in the beginning, and maximally in 24 hours. What I'm saying is maximum in 24 hours around 20 milligram. There are many sources. Many sources can, for example, say that we can give haloperidol 100 milligram daily, but I would not recommend that. I would rather give maximally 20, maximum 30 milligram, because clinically it has been shown that extrapyramidal side effects will be huge with these kind of doses. Of course, the patient will not die. Maybe these sources are dealing with the death of the patient. You can maybe give 100 milligram of haloperidol if you that would be the max if you don't want to kill the patient. But when we're dealing with extrapyramidal side effects and the side effects, I would say maximum 20 milligram for haloperidol or 30, maximum 30. But in Olanzapine also 20, 30. We have Risperidone. Here we would give 1 milligram in the beginning, and in 24 hours also around maximum 8 milligram. That you can give more, but above 8, it has been proven that the extrapyramidal side effects start to increase drastically, and the effect is not really working better if you give more. So 8 milligram is the golden lock here, 8 milligram maximum. And the therapeutic level of risperidone would be around 4 milligram. That is when we have a therapeutic level for schizophrenia. But you would, of course, as we said, see an effect for agitation already at 1 milligram. Maybe if the patient is so agitated or aggressive, you need to give 1 more, or 1 more, and so on. And usually when we treat schizophrenia patients, we give 2 milligram the first day, then we give 3 milligram the second day, and then we increase it step by step. And then the fourth day we give 4 milligram, and so on. So in a time frame of around 2 weeks, you can increase this dose to around this 4 to 8 milligram, depending on if the patient gets symptoms or not. So you continuously check every day if the symptom starts to increase, I mean extrapyramidal symptoms. If not, then we can give more and more until we reach around 4 milligram. That's the therapeutic level of risperidone. And then we stay there if it works. You don't need to increase it more. So that was Olanzapine 5 milligram, risperidone 1 milligram. So remember these values. Haloperidol was 2 milligram. And with haloperidol, because it's the first generation, we needed to give a benzodiazepine or benztropine or diphenhydramine. And then, if the patient is overweight, he's really, really overweight. As we know, unfortunately, antipsychotics can cause an increase of weight, increase of cholesterol, and increase of these lipids and so on. Therefore, if we have an overweight patient, we will give Ziprasidone, 10 milligram of Ziprasidone, maximum dose around 40 milligram. Ziprasidone does not cause weight gain so much as these other medications. So please give that one. And I think that is enough from medications. If you only know this, that you have different forms, so you have oral tablet, dissolving tablet, and then you have intramuscular injection, and you remember the doses, first generation haloperidol 2 milligram, maximum 20, you remember Olanzapine 5 milligram, maximum around 20, 30, and then you have Ziprasidone around 10 milligram initial dose, and then you have 40 milligram maximum dose, risperidone 1 milligram, and then your maximum dose 8 milligram. If you only remember this, then you have a tool, you have a tool set, you have some tools, and these are your tools as medications, as a doctor, and this tool have to be given to patients when they are, as we said, acutely agitated with psychosis, meaning positive symptom, aggression, schizophrenia, and these will calm the patient down in a couple of minutes. So hopefully you will treat patients now better if you're a doctor, and hopefully if you're a patient, you will now understand why doctors are giving you these type of medications, and which doses you should consider, and which doses you should consider with the doctor when you speak with him. So thank you very much for listening, and have a nice day. Bye bye.